Hi, Guru community. Let's jump right into the diagnosis and management of human bites. So here is the case. 3-year-old girl is brought to you by her mother after she was bitten in daycare by another child on the arm. After removing the bandage, you observe a deep circular wound with surrounding bruising. The bleeding is controlled, but it is still oozing. How do you manage this human bite that has broken the skin clearly and has some bleeding? So first of all, a quiz on human bites. What bacteria are usually involved in human bites? So there's the aerobes and the anaerobes. The aerobes are, of course, the skin bacteria, strep and staph, as well as Eichinella and Haemophilus. The anaerobes include Fusobacterium, Prevotella, Peptostreptococcus, Veillonella, and Bacteroides. What other pathogens can be spread by human bites? You have to think about the biter, right? So the biter also has a health status, and if they were bleeding at the time that they bit the other child, they're at risk for transmitting what they have, so you have to worry about hepatitis B, C, CMV, HSV, and HIV. And why are clenched fist injuries particularly dangerous, all right? So the adolescent that gets into a fight and then has broken skin over the third and fourth metacarpals, why is that particularly dangerous as opposed to the occlusional bite that we initially presented, that round bite on the arm? That's because it spreads to deeper tissue more easily. There's not a lot of padding there, right? So right underneath that skin is tendons, joints, and bones. So for that, if you see that happen, you're not going to be managing it in the office. Most probably, you're going to be sending them to the ER, and you're going to be calling a surgeon. Remember that there's a much higher risk of infection for these clenched fist injuries than they are for occlusional bites. I think less than 10% of occlusional bites have superinfection, as opposed to about 25% of these clenched fist injuries. That's hard to say. What characteristics of an occlusional bite should heighten your concern for non-accidental trauma? So on that picture on the first slide, it might actually be worthwhile to measure the difference between the canine teeth, right? So you have your central incisors, your lateral incisors, and then your canines. If that distance is greater than 2.5 centimeters to the outer edge of the tooth, then you're suspect that was done by a child, might have been done by an adult, and you have to think about non-accidental trauma. All right, here is our evaluation and management algorithm that you'll always see in these little lectures. So important history, right? Health status of the biter and the bitten, like we said. You have to worry about the immunization status of the child that was bitten. Is their tetanus up to date? Do they have their hepatitis B? And of the biter, what's their hepatitis B, C status, HIV? And then in the child that was bitten, do they have a history of congenital heart disease or a problem with their heart, such as a valve abnormality and prosthetics? Eichinella can actually cause valve disease, endocarditis. It's very rare, but you have to know the cardiac status of the child. So on physical exam, of course, do vital signs, make sure they're stable, control the bleeding. Then you're going to assess the wound, its location, right? So location is important because the arm is very different, obviously, than the face, than the genitals, than the hand, all right? So the depth, the type is an avulsion, abrasion, a puncture wound, or a laceration. If it's on the hand, you're going to do a neurovascular check. Is there good perfusion and function? And you're going to look to see if there's foreign body there. The extent, right? Is there signs already of infection? Is it localized versus there swelling, or is there lymphangitic spread up the arm, in which case you're going to rush them to the ER. That means that there is infection and it's spreading. When are you going to refer, right? So this is an important decision point. This kid is in your office and you're thinking, can I manage this here, or do I send him to the ER? So if it's clenched fist injury, if it's deep, if there's an infection concern, if it looks like it's infected, if you think repair is going to be required, or this is a child with compromised immune status, those kids, don't think about it. Send them right to the ER. Let them know a surgeon is probably going to be needed, because that kid will have to be managed on an inpatient or at least in the ER basis. Cleaning. So what do you do for cleaning? Soap and water or iodine. You're going to irrigate non-puncture wound, right? You don't irrigate puncture wounds. So non-puncture wounds, you're going to use normal saline or tap water. If you think anesthesia is going to be required because it's going to hurt, don't manage it in the office. Cleaning is probably the most important thing to reduce risk of infection. Send them to the ER. Debride, remove foreign material. That's probably going to happen in the ER. And if it's a clenched fist, non-occlusion bite, you're going to get an x-ray to take a look at the underlying tissues, look for an abscess, see if there was damage to bones or tendons. And then culture. Do you routinely do a culture? No. But if it's greater than 8 hours old, right, they present late, or after the event, or there's signs of infection, then you will do a culture. How about wound closure? So let's look at our little algorithm here. So if it's on the neck or the face, Yes, that's the only time you would consider closure. Closure increased the risk for infection, but because of cosmetic concerns on the neck or face, you might consider closing it. You're going to close with sutures, not the kind that dissolve, nothing subcutaneous, unless infection signs, right? You're not going to close if there are infection signs or if it's greater than 8 hours since the injury. And if you do close, these kids are going to be on antibiotics for sure. If it's not the neck or the face, generally you do not close, especially on the hand. You're going to allow it to heal by secondary intention. How about infection control? Like I had mentioned, remember, less than 10% occlusional bites actually result in infection, and about 25% or so of clenched fists result in infection. So what do we do here? First question, is there broken skin? If there's no broken skin, no antibiotics, move on with life. Maybe you'll do a wound check in 24 to 48 hours. If there is broken skin, doesn't immediately mean you're going to put them on prophylactic antibiotics. The risk for infection is still low. But if there's immune compromise, risk for endocarditis, we talked about that valvular disease and what Ichinella can do. If it's greater than 8 hours old, if there's hand, face, or genital involvement, if it's a puncture wound or concern for bone, joint, and tendon involvement, that is, right? So broken skin alone is not enough, but if there's broken skin plus these risk factors, you're going to put them on antibiotics. And what are you going to use? You're going to use Augmentin, right? Because Augmentin covers for Ichinella. Ichinella is resistant to first-generation cephalosporins, aminoglycosides, and the like. So you're going to use Augmentin, or you're going to use Bactrim and metronidazole to cover for anaerobes. And remember, this is prophylaxis, right? No sign of infection. You're doing it for at least 3 to 5 days, right? And then you're going to consider tetanus status, which we will on the next slide. And then very important in these kids, you do a wound check, right? You're going to do a wound check in these kids 24 to 48 hours to make sure that this prophylactic antibiotics was enough and that you don't have to either send them to the hospital for IV antibiotics or prolong the antibiotic course. All right, how about tetanus prophylaxis? Human bites are considered dirty wounds. When you look at that tetanus prophylaxis chart, everybody's seen it, right? Clean wound, dirty wound, this is considered a dirty wound. So broken up into 3 categories. If that child has greater than 3 doses of tetanus and the last one was less than 5 years ago, doesn't need anything. No vaccine, no tetanus immunoglobulin. If they had greater than three doses and the last one was greater than 5 years ago, then you give them the shot, the Tdap, but not the immunoglobulin. If their immunization record is incomplete or they have unknown vaccine history, you give them both Tdap and the TIG, the tetanus immunoglobulin, both of them, okay? There are alternatives to HTI, human tetanus immunoglobulin, and so what do you do if that is not available? So the first option is something called equine tetanus antitoxin. That's the first line. Just know that before you administer this fully, it has to be given subdermally or subdermally to make sure there isn't a hypersensitivity reaction before you administer it fully. You can give IVIG because presumably the donors actually have antibodies to tetanus, so IVIG is sufficient. And then there's a new medication. It's a monoclonal antibody called, I'm going to try to, siltartuximab. It's not broadly available yet in the United States, but it's actually shown superiority and effectiveness to HDIG. So there are alternatives to HDIG. All right, thanks very much for sitting with me through that on our lecture and diagnosis and management of human bites. A few things. Great review article, 2025 review article on bites. That's the most recent one, actually. If you want to get a hold of that algorithm, please check me out on Substack. There you can actually download by subscribing for free. You can download the PDF of the algorithm I just showed you that you can take and use in the office. And then coming soon, there will be a general pediatrics course that goes through all of general pediatrics. The general pediatrics playbook course will be coming soon. And then finally, please email me pediatrics@higuru.com with any feedback and comments. Thanks so much.